Part two. Okay, we're going to dive now into the drugs used to treat schizophrenia primarily, and how they work and how they're classified. All right, treatment. So before I go into the drugs, though, let's talk about non-drug treatment. I did mention before that things like cognitive behavioral therapy can be effective in treating depression and other disorders too. So it's always great if you can find a treatment that doesn't involve taking drugs for the rest of your life. So a big fan of cognitive behavioral therapy, and other talk therapies can be helpful, but not for depression, but not in the case of schizophrenia. It's been found that especially for the positive symptoms, cognitive behavioral therapy or other types of talk therapy are not very effective. So that's very sad. There doesn't seem to be a nice behavioral level treatment for schizophrenia. Again, people tried that for decades and end up institutionalizing people and chaining them to their beds because they couldn't control their behavior. And so sadly, these talk therapies just were not very effective. Now, I mentioned the positive symptoms. We know that these kind of more cognitive behavioral therapies are not useful for the positive symptoms. Negative symptoms, well, maybe. We know that the CBT can be somewhat helpful for depression, and the negative symptoms are similar to depression. And we don't really know for sure, but they may help, but it's not a huge help. But it is at least one tool that a physician or psychiatrist can use to help maybe their patient. Some might be responsive to that, but again, it's not very effective. And we've already talked about other treatments that haven't been terribly effective, or at least were horrific, like electroshock therapy is not very effective in schizophrenia. Diet changes are not very effective. Cold water baths, lobotomies, not so great. Upshot is the best way we know of treating schizophrenia comes down to drugs. So what are the outcomes of treating a schizophrenic patient with drugs? Okay, now I've already mentioned that the best thing we've got to do to treat schizophrenic patients are drugs. And by the way, I'll just mention now that the drugs we have, like chlorpromazine, things like that, Thorazine, these drugs that people who have schizophrenia take, it can help about 50 to 60% of patients, which is pretty good. It's very sad for the other 40% that aren't helped, but on the other hand, that's not bad for, at least in modern day medicine, for treatment efficacy. But what is the outcome, though? What are the kind of the types of outcomes if you have schizophrenia and you're taking a drug that you can expect? I like this because this kind of summarizes where somebody might end up. You come into the doctor, you're diagnosed with schizophrenia, you're given them drug treatment. Here's a pie chart, this kind of rule of thirds that we'll call here, where you're probably going to end up one of these three categories. In 1/3, your outcome is really good in the sense that you respond well to the drug, you can keep a job, you have a relatively normal social life. It's like John Nash, or I forgot her name, Evelyn Sachs, I think, but she was that lawyer. So if you're in one of these very high functioning schizophrenics, but then you have a lot falling into this mixed category, another third. You do improve your symptoms, but you get these relapses. You often have to be hospitalized because this is kind of like Evelyn Sachs before she could figure out her treatment. Reduced employment. You get social isolation, and you do need assistance on the day-to-day basis. So it's not great, but it's not as debilitating as if you weren't taking the drugs. And then you have these other outcomes of people who just don't respond to the medication. We can't figure out what works best for them or how to treat their disorder. And so they spend a lot of their time hospitalized or in jail or other things, or homeless. Unemployed, poor social interaction, very low level functioning. And so that's like the worst outcome. So it's this rule of thirds. 1/3 have a good response to the medication and treatment, 1/3 have a mixed, and about 1/3 really have it hard. All right, on the previous slide, I showed kind of what the outcomes can be if you come into the psychiatrist's office and you have schizophrenia and they give you a drug, you have this rule of thirds, that in 1/3 of the cases you have pretty good outcome. Another third, it's like, yeah, you're better, but still life ain't great. And then another third, well, life just is terrible because you're not being treated. Okay, well, the treatment comes down to these either first or second generation antipsychotic drugs. And a mixture of these first or second generation antipsychotic drugs are listed here. And this just gives you an overall view of just some of the many, many antipsychotic drugs that are out there. Chlorpromazine is the one in the upper right corner over there. That was the first one to be discovered. And then clozapine was discovered relatively quickly afterwards. These are the first and the second generation antipsychotics, and all of these are also first and second generation antipsychotic drugs. But what this is showing you is the relationship between how well the drug works in treating a patient and how well it binds with dopamine receptors. And it just shows this positive relationship between the drugs and its ability to bind with dopamine receptors. All right, so we know there's a dopamine connection. All right, going into that, I now want to break down the current treatments, the pharmacological treatments, the drugs used to treat schizophrenia, into the two broad classes they're put into. You have the first generation antipsychotics and the second generation antipsychotics, the FGAs and the SGAs. Other words for the first generation, they're often called neuroleptics or typical antipsychotics. And the second generation, they call them atypical antipsychotics. So I'll use both terms interchangeably. They both the first and the second, block D2 receptors. We've already learned that. The only thing that differs with the second generation is that they also block serotonin receptors. But then you might think, aha, well, is the serotonin receptor involved in schizophrenia? Probably not, but we think that perhaps a blockade of serotonin receptors might help with some of the symptoms of the drug itself. So that could be, so it doesn't point to a new mechanism as to how schizophrenia is generated, but it might just help alleviate some of the negative symptoms of some of these drugs. And again, these drugs have a lot of negative symptoms. All right, the first generation antipsychotics are the most frequently used. They have very bad movement and motor side effects. I'll talk about tardive dyskinesia and extrapyramidal motor issues as well in a moment. But a benefit of these first generation drugs is that they have very long half-lives, which means they stay active in your body and brain for a very long time, which can be a really great thing for treating schizophrenia, because one of the biggest issues you have with schizophrenia is that the patients don't keep taking their drugs. They have cognitive issues, they have attention issues, they might have memory issues, but even more so, a lot of these medications have pretty crappy side effects, as we will learn. And so getting compliance and people to regularly take these things can be really tricky. So if you can get a drug where you don't have to take it every couple hours, and you can take it at 20 to 40 hours, once every 20 to 40 hours, like once every day or two, that's much better. You'll get much better compliance if it's not as often. All right, and so that's a big advantage of first generations. The second generations, like I mentioned too, they're kind of unique in that they also bind to these serotonin receptors. One of their advantages is that they don't have as severe movement side effects, but they do have side effects, and so neither one is a silver bullet here for schizophrenia. All right, so what's common? I already mentioned these first and second generations both block D2 receptors, both have nasty side effects, both treat the positive symptoms of schizophrenia, but we're still at a loss pretty much with treating the cognitive and negative symptoms of schizophrenia, especially with drugs. Many of these first and second generations are used off-label for other disorders. We've already mentioned One of those disorders, or two of those disorders, we talked about bipolar disorder. So antipsychotic drugs can definitely be used to help treat the bipolar, especially that manic phase of bipolar disorder. Even major depressive disorder, where you don't have a manic phase, can also be treated sometimes with these antipsychotic drugs. Post-traumatic stress disorder, and dementia as well. The big issue, though, with dementia is it can be dangerous because, as I mentioned, these antipsychotic drugs have a lot of negative side effects, and those side effects get more serious as you get older, and so it can be more deadly for people to take these drugs as they get older. Now, I mentioned there's a lot of these things. There are a lot of these different drugs out there. Abilify, I just showed you the risperidol, but there are like 30 plus drugs available for treating psychotic disorder, schizophrenia. And this gives the doctors at least a lot of tools to try to tailor the medication to the patient. And often it might be one drug might be more effective in general, but often it's like one drug just has fewer side effects than the other, and they might treat the symptoms the same, but you're just trying to find one that's a little more palatable for the patient. All right, just as a note, I mentioned this before, but this drug kind of goes to town on all of the specific drugs and all the specific names. And I personally can get lost in a world of all these specific drug names. So I'm going to pretty much reduce it to just a few. So just the drugs that I mention in these slides explicitly are ones that you'll really have to memorize. Read all the stuff in the chapter. It's not that long of a chapter. And it'll help give you the thing. And I think the intro of that chapter is very good. And I think reading about the drugs lets you learn more about how they're working and how schizophrenia might be enacted in terms of the dopamine system, but don't have to memorize them all for sure. Okay, so the ones you should know for sure are these two classics, thorazine or chlorpromazine and clozapine. So the first one is a first generation. The chlorpromazine is a first generation antipsychotic. It was the very first one discovered. So again, 1950-ish, like early 1950s. And the response rate is really high with this drug, even though, I mean, it was developed back in the 50s. And it's just as good as pretty much any other anti-schizophrenia drug that was developed from that point forward. And it's a first generation, and like any schizophrenic antipsychotic drug, it blocks D2 receptors. All right, the other one you should know is clozapine. That was the very first drug developed as a second generation antipsychotic. This is one that not only blocks the D2 receptor, but also blocks these 5-HT1A receptors, which, by the way, we linked to depression in the previous set of lectures a week ago, but also binds to, or blocks, not binds, but blocks the 5-HT2A receptor, which, if you remember, is a receptor we think is really key for hallucinations in psychedelics. And so I would bet pretty highly that if you're taking clozapine and then you really want to trip out on your LSD, that you're going to be disappointed because clozapine will be blocking your 5-HT2A receptor and you won't get the vivid visual hallucination that you were hoping for on your LSD, given the connection between the 5-HT2A and hallucinations. All right. So the clozapine I mentioned has the second generations in general have a little less of these nasty side effects in the form of motor side effects, like movement side effects, which I'll talk about in a moment. So that's one benefit to clozapine. And it does seem to be pretty effective in reducing deaths in general, and especially by suicide. So clozapine, the second generation, is good at that. And it generally tends to be clinically more effective, even though it also developed in the 50s, more effective than pretty much all the other antipsychotics, but it's a dangerous drug. I'll say that the reason maybe it's not prescribed as much is because if you're not really careful and test it often, you can die. But overall, if everything is done right, it's actually superior to most other drugs. Pretty much all of the drugs, if done right. It's effective in 1/3 of patients who aren't responding to one of the other antipsychotic drugs out there. So that's also great. So if you have somebody who you're finding the medications aren't working, try out clozapine. You might have put it off because of the side effects, but try it out, and that might actually be helpful. And overall, it's underutilized, given that we know that it's pretty much more effective than the other antipsychotics. It's just not used perhaps enough. We already know it's saving people's lives because it reduces suicides. Why wouldn't everybody just give them that drug? Well, the main reason is that it is dangerous if you're not careful. It requires frequent blood tests, which I would imagine most patients aren't too happy about. But those blood tests are required to test for this thing called agranulocytosis, which boils down to meaning your immune cells are going away. They're disappearing, your white blood cells. As a result, your immune system's falling to pieces. If you're not careful, if you do it right, you have the right dose, your immune system's fine. But if you're not getting these regular checks, you could have this agranulocytosis. So that's one reason why it's not used as often as perhaps it should, since it's so effective. All right. Side effects. Going back to first generation antipsychotics. What's to look forward to there? Well, the first one are these extrapyramidal symptoms. So it relates to the pyramidal motor fibers, these neurons that control your movements. And these are really problematic. I'll talk about them in the next slide, but they're these really uncontrolled movements that can develop over time, kind of similar to Parkinson's disease, and that's from taking these medications. You get sedation. Not always, people don't like that necessarily. You can get anticholinergic symptoms. So if you remember that acetylcholine from your sympathetic, parasympathetic knowledge from back in the beginning of the class, that the cholinergic system, acetylcholine, is important for your parasympathetic, your kind of relaxation, you relax, slow down the body, go back to homeostatic kind of maintenance mode. But if you block it, then the balance tips into the fight or flight sympathetic response. And so, sure enough, a lot of these drugs can actually block acetylcholine system and then lead to all these things associated with the fight or flight response, like urinary retention, dry mouth, those types of things. And then other things that aren't so fun too, disorientation, constipation, memory problems. As we mentioned, acetylcholine is very important for memory. All right, so those are issues. Then you get endocrine systems. So basically, endocrine, if you remember, are like all those hormones that your pituitary might dump into your bloodstream that control your hunger, your weight, your body temperature. Well, sure enough, these drugs too, these first generations can screw that up as well. And you can get weight gain, breast enlargement in men, so that they don't necessarily like that. You can actually trigger females to start lactating. As I might have mentioned before, but that's interesting to me now I think about it, because some of these the dopamine receptors do control, or dopamine does control lactation. In fact, dopamine release, I think, is associated with lactation. And so if you start screwing with the dopamine system, I guess I can imagine how that might trigger lactation. All right, skin. Yeah, for some of these medications, these first generations, it can make you really hyper photosensitive. You get super sensitive to sunburn, things like that. This might relate to depression too, is that you get sexual dysfunction. So similar to some of the cases, some of the situations you get in depression. You get anorgasmia, can't have an orgasm, decreased libido, your ejaculation stopped. So major sexual dysfunction. And there are ocular symptoms, your eyeballs. So that's another bad one, in that your field of view, as I show in the plot over there on the right, can get narrowed. And that might relate again to the dopamine system. Dopamine's actually in your eyeball too. But I'm not sure. I don't know if people know why this occurs sometimes. But you get this thing called retinitis pigmentosa, where your field kind of views to a narrow area. So it's very terrifying. And so you can see why compliance is an issue with taking these medications. All right, I talked about these motor symptoms that might be an issue here. Well, there are two stages of these symptoms. The first one comes on a little earlier. So the first use, when you start using these first generation antipsychotics, you get what is called dystonia. And so what that is that your muscles contract uncontrollably, you twist, that type of movements, you just don't have control of your body anymore. And these movements are very repetitive, often, or you can get into this contorted, abnormal posture. And so this can be painful, this can be uncomfortable, this can make you kind of feel like a social outcast, it can screw up your sleep. So all these issues kind of arise from this dystonia. And again, dopamine is important for controlling your movements. And so this might again relate to dopamine's effect on the body. And if you're blocking these D2 receptors, that could very well be a component. All right, if you're taking these first generation antipsychotics for a very long period of time, another thing can develop called tardive dyskinesia. I've mentioned dyskinesia before in the context of Parkinson's disease, and this is essentially this very similar, very similar thing, is that long-term use of these drugs can actually result in these more hyperkinetic, bigger movements. So I mentioned these little contractions in the dystonia, but these are much more ballistic movements, rapid, jerky movements that can occur from long-term use of these first-generation antipsychotics. And again, very similar to these dyskinesias that occur in Parkinson's disease if you're taking levodopa day in and out, or L-dopa is the same thing for Parkinson's disease, is that they hypersensitize your system to dopamine, and you essentially lose control of many of your motor functions when dopamine is released in the brain. All right. So just as a thought exercise too, my own lab, we study in my lab how ketamine might help reducing these L-dopa induced dyskinesias in Parkinson's disease. Just as a thought exercise, why do you think this is maybe not the best idea for treating people with schizophrenia? All right, and I'll leave it at that. All right, Parkinson's. Oh, this is a point of clarification I just want to bring up. Often people will use the term Parkinsonian, which means Parkinson's-like. It doesn't necessarily mean the person has Parkinson's disease, which is a very specific disease affecting these dopamine neurons. It's caused by a very specific buildup of these different proteins, and so like alpha-synuclein. And so I just want to point out that anytime you get like motor symptoms that might not relate specifically to Parkinson's disease, but pretty much look exactly the same and might have, in the end, also relate to dopamine dysfunction, they often call it Parkinsonian. I just want to make that clear so that it doesn't get confusing when people say Parkinsonian and Parkinson's disease. If you're Parkinson's patients, you have Parkinsonian motor symptoms, but you don't necessarily need to be a Parkinson's patient to have Parkinsonian-like behaviors. And schizophrenics who take these medications develop these Parkinsonian-like motor behaviors. All right. And some of those motor behaviors that they also can develop after taking these medications are bradykinesia, which is just slow movements, and these tremors and rigidity too. And there's this also, I can't remember if we mentioned this when I was talking about Parkinson's disease, but there's this cogwheeling, or I wasn't talking about it, I'm sorry, one TA's was. So, but in Parkinson's disease, you get this feeling in your arm, like if I met a patient and they were coming up to me and I was like, feeling their arm, just moving their arm around and trying to move it here and there, you'd feel like these really jerky, staccatic, kind of uncontrolled little ridgy, again, ratcheting kind of movements in their muscles. And you can sense it while you're kind of moving or rotating the limb. And it's a symptom of Parkinson's disease, but you also see that from taking these first-generation antipsychotics. All right, the second-generation antipsychotics, how they work also is blocking those D2 receptors, but they also block these 5-HT2A and 2A receptors. But they have, fortunately, less of these motor side effects. But they have other issues. they are, on average, as effective as the first generation for schizophrenia. But again, sometimes it's a patient-by-patient issue. And some of these, as I mentioned just briefly before, like clozapine, can have serious issues like this agranulocytosis that I mentioned when your white blood cells die. And if you're not careful in doing regular blood tests, that is a very big negative there. And as I mentioned before, weight gain because of the endocrine issues with these are particularly bad with the second generation antipsychotics. So it can make you gain weight, especially in terms of, in the case of clozapine. Just to illustrate, here's some of these drugs as well. They're just different antipsychotic drugs. I think this is a mixture of first and second generation antipsychotics. But there you have clozapine way on the right over here. And that's a patient gaining weight. So you have 55%-ish of patients gain weight when they take clozapine. So that is another reason why compliance might be more difficult, even though it's very effective, and that people aren't necessarily happy when they get really fat when they're taking a medication. So you can see that. Okay. What's better, first generation or second generation? Well, there's no really right answer. They all have their trade-offs. Overall, generally, one is not better than the other. You have to, again, tailor it to the patient and take into account not just how effective it is at reducing the positive symptoms, but how many of these nasty side effects occur too. So you might have to choose a less effective drug if the side effects of the first one are so bad. A UK comparison study pretty much showed that there was really no difference between the two groups. The first generation, in fact, some mention at least the subjective quality of life scale improvement in patients were a little bit better in the first generation. And overall, and this is again on all these drugs, and overall there's no difference in the general effectiveness though. And I mentioned that actually clozapine can be quite effective in many situations, but you have to keep very careful about it because of the agranulocytosis and the weight gain and stuff. But to me, the sad thing here is that both clozapine and chlorpromazine, all these drugs at least those two drugs were developed in the 1950s, and we just haven't gotten any better. And so it's sad that we haven't been able to figure out how to properly treat, and we can't treat the negative and cognitive symptoms of schizophrenia. So that brings up the question, well, what's next? How can we get past this barrier? Well, people have been trying. Third generation, we're not there yet, but there's some new drugs that are showing promise. I'll just mention this one. So now you've only got 3 specific drugs you need to remember. So again, I'm trying to keep down the 30 or so that were mentioned in the chapter down to 3, but Reprazole or Abilify. So that one also kind of acts very much like these second generation antipsychotics because it acts on the D2 receptor and the 5-HT1A and other 5-HT2 receptors. All right, but what's unique about it is that instead of being an antagonist for the D2 receptor, it's a partial agonist of the D2 receptor. So that's weird because everything else has been an antagonist of the D2 receptor. So here we're getting at maybe a different mode of action that might be a better route for treating it. Jury's still out, but this might be a good way to go. So what it's doing is, well, how could it possibly be beneficial if it's actually doing effectively the opposite of what the other drugs are doing? Well, it kind of makes sense. If you remember some of our other discussions, I think way back I might have mentioned this in context of buprenorphine for treating opioid addiction. It helps people go through withdrawal on opioids. It was also a partial mu-opioid agonist. And these partial agonists just means they're effectively a crappy agonist. So they're an agonist for the receptor, but they're just not very good at their job. As a result, they sit around in the binding site of the receptor just doing kind of, again, a half job of what they should be doing. But while they're sitting there, they're preventing the actual dopamine from getting where they need to go. And so even though they're agonists, they're kind of acting like a moderate antagonist. So by preventing the regular amount of dopamine from activating that receptor. So they kind of keep things under control. And so that might be why they work. So they might not be blocking the receptor, but they're just not making it very efficient. And so that's an interesting route. And another thing that might be very hopeful about this particular drug is that it might actually work on the negative symptoms. And that would be revolutionary because currently none of these antipsychotic meds works on the negative symptoms, kind of like the depression-like treatment. And it actually, if used in combination with SSRIs, they also, this ariprazole might actually be useful for treating depression itself. So it's hopeful. So there is hope on the horizon, and it's about time. All right. Let's go. Okay, that is a reminder. We have made it to the end of part 2. There are only 2 parts in this segment, and so congratulations. And again, if you have any questions, please fire me an email. Email the TAs. I just remembered, just as an update, some of you have done the SONA system stuff, where you've done work where you volunteered for different psychology experiments and then get credit. I guess the data as to whether or not your credit was recorded is in the SONA system, so you actually have to look up your score in the SONA just to make sure that they gave you the proper credit for that, and then we'll transfer that over. But yeah, that was just an announcement that TAs had mentioned. You're welcome, though, to ask. Maybe contact the TAs if you have specific questions about the SONA being transferred, but we will make sure you get your credit if you've done, let's say, an online experiment or something like that through the SONA system. All right. With that administrative thing out of the way, again, I will have a review session then next week, in person, live and recorded, believe it or not, live. And looking forward to even seeing some of you, or some faces out there. And have a great weekend, and really enjoy the class, even though unfortunately we had to be online for half of it. And again, have a great weekend. All right, bye.